Okay, hello. Welcome everyone to a Thursday VMR. We're so excited that you all are here. I'm very excited for today because I had the amazing privilege of getting to discuss a case with Robbie, the one and only, and would love to hear if anyone in the audience here has a case they would like to present.
While we wait for somebody to respond to that appeal, please, any case would be highly. I can't think of the right word. A coveted case. But let me prove to you that Madalena is speaking not truth about me being the one and only. Let me show you. Let me show you the most popular image of this guy. This guy is the most popular Ravi Jiha, in fact. And I will venture to say that he is way more photogenic than this Ravi Jiha.
Who is that other person?
Yeah, look at this guy. Come on. I want to be him. So, no, I'm not the one and only Ravi Jiha. But I'm honored. He does look like House MD, doesn't he? Oh my God, like two people, Nikita and Heinrich, both. Yes. So yes, we've solved that riddle. There are many, one of whom is I think way more visually appealing than I am. Thank you for your kind words. I appreciate it. I listen to Deborah now much more because she is an influencer on social media. She might tell you more. Yeah, anyway, at the risk of completely demolishing this nice get together, yeah, I would love for you guys to jump on in. Anybody, any case for Madalena and I to reflect and nerd with you about. Anyone, come on. There's so many gems buried in here. It's such a shame. Any case, I swear, a pneumonia, COVID, pre-renal AKI, a rash, a case of the silent 30-minute VMR, anything.
I promise I would. I've got my steps to exam in 5 days. I wish I'd brushed up on a case that's in my mind right now. I'll have it ready next time, okay?
That's totally okay, Andrew. Thank you. No worries at all.
I think I may have one, but it's like, I don't know, like how interesting it might be.
Oh, I promise you. You know, I learned yesterday that if you put any food in front of me, I get to put a little seasoning on it, I will make it delicious. So the very fact, Yasmin, that you're presenting this case means that the seasoning is delightful already. And
Thank you.
Madalena will add to it, I'm sure. But yeah, just go for it.
Yasmin, okay. Thank you for presenting.
It's good. It's short and sweet. So let's see.
Perfect.
It's a 29-year-old man with dyspnea and mild chest discomfort.
Sorry, I was looking for the mute button. Okay, so dyspnea and mild chest discomfort. Those are two very, very broad chief concerns. And I feel like I actually have kind of an approach for each of those. So it'll be interesting to discuss kind of how they overlap. But for dyspnea, well, I guess actually first, why don't I start off that in past VMRs, I feel like Robbie has actually framed diagnostic reasoning kind of in two buckets. And the first one is collecting data, and the second one is kind of solving the problem. So clearly, after only just a few words, we're very much in the data collection phase. So we need to ask about the time course here, which will be really important, kind of associated symptoms like bilateral lower extremity edema, kind of orthopnea, things like that. But for dyspnea, which I guess I'll start with, that has a very, very large differential. So when something can be so vast, you want to think about the base rate. So what are the most common causes? Because that's really going to help. Yeah, you just want to focus on what's most common. So in the various VMRs I've listened to, we've talked about how 95% of the causes of dyspnea are kind of localized to the heart and to the lung. So because of that, that helps us guide the further questioning about edema, orthopnea, things like that. And then within kind of the heart and the lung, you can take an anatomical approach. So for the lung, for example, you can think of airways, alveoli, the interstitium, the vasculature. For the heart, you can think of myocardium, arrhythmias, endocardium. So I think what I'm taking away here is that you want to take a base rate approach, and then also because of the high morbidity associated with conditions with chest pain, you want to rule out some of the life-threatening causes, and we can talk about kind of the 4+2+2 approach for that. So that's where my mind is going right now, but definitely want to know about the time course here, which will be really important. Robbie, what do you think?
I'm eating my apple because I don't know why I'm here. You got the solo, so I'll just ask questions.
Okay.
What do you think the presence of dyspnea does to your workup of or your analysis of chest pain? So take your mind and put it in the chest pain world, in that chest pain schema that you just outlined so well. Then ask yourself, what does the presence of shortness of breath modify in that landscape? What do you think?
So the presence of shortness of breath, okay, so if we're thinking of the overlap of chest pain and shortness of breath, I'm kind of narrowing in on pulmonary causes, because if there's dyspnea, there's some issue with breathing here. So I'm prioritizing the pulmonary causes a little bit more.
Yeah, you're
Yeah,
thinking
kind of going back and forth.
That's absolutely superb. That's exactly right. So ask yourself, are patients with GERD, costochondritis, zoster, and all the benign causes of chest pain going to have shortness of breath? And the answer is absolutely not. So quite simply, the presence of shortness of breath in a patient with chest pain further prioritizes the morbid causes and takes the distance between you and a benign diagnosis and puts it even further away. So the chances that you're going to call this GERD or something benign and discharge the patient is much, much, much lower. And that kind of analysis proves to you that in a patient who has both chest pain and shortness of breath, you can take the chest pain and toss it out. It doesn't help you because the shortness of breath is a much more morbid consideration than is chest pain. So to simplify the part of the problem solving strategy that you were outlining is trying to simplify the problem as much as possible. And so I would approach this case. This is the patient who has shortness of breath, and the chest discomfort only reinforces the notion that this is something serious. I think it would be a little bit less efficient to entertain all the causes of chest pain, because they'll also include things that are much more benign in nature that I'm probably not going to diagnose in somebody who's short of breath. So the more you think about this exercise, I think the more I've come to realize that the chest pain does nothing for us here. And everything that we're going to find in the shortness of breath schema is going to be in chest pain. But there's many things in the world of chest pain that won't explain the shortness of breath and therefore are irrelevant. So yeah, for me, I think this boils down to just use dyspnea. And I'm curious, since this thought may be fresher in your mind than it is mine, I'm kind of like, it's months old in mine. Does that resonate? Do you find any holes in that, or does that make sense now that you're like rapidly processing it?
Does it make sense to really narrow in on the dyspnea and exclude the chest pain?
I mean, I just presented you an argument. Does it land with you? Does it make sense, or do you feel like it doesn't quite jibe?
I think I'm a little bit hesitant to fully embrace that, just because of, when I think of the do not miss causes of chest pain, they're so serious, and I just wouldn't want to miss those because of the morbidity associated with that. So I think at least for right now, I would be kind of holding both of those in my mind.
100%. Let's go through that. So ACS, it's 2 A's, 2 T's, right? ACS. You think cause shortness of breath?
So sorry, what did you say?
So let's go through that. So look, we're going to focus on the morbid ones, right? And so the four morbid ones in terms of chest pain, in terms of cardiovascular causes of chest pain, are ACS, aortic dissection, tamponade, and Takotsubo. There?
Yeah.
Do you think ACS can cause shortness of breath?
Yes.
Aortic dissection?
Yeah. Why not?
You're a little bit hesitant there, right? Yeah, it's a little bit less likely to cause shortness of breath, but it can.
Yeah.
Tamponade can cause shortness of breath.
Yes.
Yeah. Takotsubo.
Yes.
Boom. Pneumothorax.
Yes.
PE.
Yes.
Esophageal rupture.
Yes.
Yeah. See, that's the crazy part, is when you look at all those things, they all cause shortness of breath.
Right.
And I think if we could do that schema over again, I would probably put like onto the arrow of big clue that there's an emergent cause is presence of dyspnea. So
Okay.
yeah, let's put a pin in that and reflect on that later. But I think it really is, once you think about these, and once you've like put these schemas together, you're like, wait, hold on, all those things cause shortness of breath.
Yeah.
But right, like some of them may not, like an aortic dissection may just present with a pure pain syndrome. But for all of you, like look at those two schemas and ask yourself, like, all those scary things in chest pain, do they exist in shortness of breath or not? I think most of them do. Yeah. Cool. All right, Yasmin, give us more, please.
So this patient started with dyspnea 3 months ago. The dyspnea was persistent during this time without limiting the daily activities. Also, there were no aggravating or alleviating factors. He had no fever, no dysphagia, no additional pain, no syncope. Should I just give you the medical history to go a little bit faster? Our patient is a smoker, a 4-pack year, and he has no additional medical history. He denies alcohol or any drug use or past medical issues. The only history here is that he's a smoker, 4-pack year.
Okay.
It's just cigarettes.
Yeah. Cigarettes. Got it.
Yeah.
Okay, Yasmin, just thank you again for presenting this really interesting case. So when I'm thinking through cases, I like to frame a problem representation kind of as soon as possible because it just helps me summarize the way I'm thinking of the case. So the problem representation is the who, so kind of the kind of background of the patient that we know, the age of the patient, the what, which is the problem we're trying to solve, and the when, which is the time course. And the time course is especially important because that really helps us filter the differential, but then also kind of the severity of what we're dealing with. So if I were to try to build a problem representation, this is a 29-year-old male with a past medical history, or with a past history of smoking, 4 packs per year, presenting with 3 months. So that's kind of subacute to chronic, maybe leaning more on the chronic, subacute to chronic dyspnea with no alleviating factors. So the value of this problem representation, at least at this point for me, is the time course. So the fact that this is subacute to chronic helps me prioritize certain things. So for example, if this were acute, we would think about maybe an obstruction or an electrical discharge, like an arrhythmia, versus if it's subacute to chronic, I'm thinking more of maybe some infections or autoimmune causes. So that's what I'm thinking of right now. But kind of from what Yasmin has just told us, the really key things I'm keeping in my mind right now are the time course here, and then the smoking history to see if the smoking history has caused some damage to his lungs and could be contributing to this presentation. What do you think, Robbie?
I think it's so key that you picked up on the time course. I think that's the most powerful modifier here, is the fact that it's been going on for 3 months. Yeah, I completely agree with you. I think that's the most most powerful variable. I love that you also snuck in a schema for sudden onset. That was really, really nice, and how those things are much less likely. And I think if you're putting yourself in real life and you're taking this patient in the emergency room, for example, or maybe in clinic, you're going to do an exam. Curious just for us to practice, like when you see a patient like this, what would be your reflex orders that you'd want to obtain, say, in the next couple of hours? Like, what data would you want at your fingertips? And that's not a fair question to ask now because the exam might modify that. But say you're trying to practice that before you get the exam, what would you be inclined to get before?
So besides the vitals, which will clearly be helpful, especially like the O2 sat, I would want to get a chest X-ray for sure. And I would want to get some basic labs like a CBC. I think some people in the chat talked about how anemia can cause shortness of breath. So a CBC would be helpful. Definitely a chest X-ray. And anything else here? Those are my initial thoughts, just some basic labs and some chest X-ray.
100%. I think that's true for the vast majority of people. The CBC renal panels will look for metabolic acidosis. Definitely still under the basic chest X-ray and then maybe an EKG. One thing that comes up a lot, and the reason I ask this question is, how do you think about getting VBGs for? So say the O2 sat is normal. How do you break down thinking about getting a VBG in a patient?
Yeah. So a VBG will be helpful because we could see if there's any acid-base abnormalities. I think you just mentioned, and other people in the chat have also mentioned like acidosis that can cause dyspnea.
100%.
So I thought it'd be helpful to look at for acid-base issues.
Yeah. You'll see that most people don't get it initially, and I don't know what the right answer is. I think we should all just think about it. The time that I think it's ordered more often is when you detect wheezing on the exam to see, oh, this is person have COPD or something like that. And I think it just goes to show you that detecting hypercarbia, which is really what you look for, as you were saying, acid-base issues, is much harder. So for me, I've been thinking more and more about it. Like, what is it that will prompt me to get a VBG in a patient? And I think it probably would only be if we get wheezing on the exam. But I think the broader point that you're making is that even now, with just talking to the patient for 5 minutes, probably in real life, you're inclined to get a fair amount of data. You're inclined to get labs, imaging, and X-ray. And it goes to show how morbid shortness of breath is and how often, no matter what your schema is for shortness of breath, you're going to need to get basic labs and EKG and an X-ray. I love that you brought out that point. Alrighty, Yasmin, let's get some more. By the way, are you noticing I'm not adding any or commenting anything on Madalena's clinical reasoning? It's like an utter waste of time to do that. So we're trying to add in some spice in other ways. All right, Yasmin, give us more, please.
Okay, so this case, my colleague, my friend, I have been pestering them like, hey, do you have a case? Do you have a case? So I don't really have all the like stacked vitals, but he had no fever, normal temperature, normal heart rate. This patient was tachypneic, but here he told me this tachypnea was exacerbated during palpation. Now, on vital exam, the vital signs were normal. Breath sounds normal. Cardiopulmonary was also normal. Abdomen normal. No abnormalities in neuro exam, and no abnormalities on extremities or skin. There was no arrhythmia.
Okay, Yasmin, did you want to give us any additional information, or should we stop here?
Can give you labs right now, but I'm gonna tell you that it's also all normal. They did hemoglobin normal, white blood cell count normal, electrolyte normal, glucose normal, calcium normal, liver function tests are normal. They even did a panel for tuberculosis was negative. And I don't know if you want to, he has a X-ray and CT scan. But I think that it will be like easier if I just give you this.
Yeah, we can pause here for sure.
Okay.
This is very fascinating. Okay, so I just wanted to clarify one thing. So for the vitals, you said tachypnea exacerbated during,
No, during
was it
palpation. I'm
palpitations or
sorry,
palpation?
it's palpation of the right side of the neck, chest, and back. I'm so sorry, I didn't like. Yeah.
So tachypnea exacerbated during palpation of the neck, and what else?
During neck, chest, and back palpation in the right side.
Neck.
Yeah.
Okay.
Because the patient, and here's my other note, they have everything around. So the patient mentioned that it was discomfort, not so much pain. That's how he explained it.
Got it.
Mhm.
Okay. Okay. Good to know. Well, first of all, what's reassuring is that the vitals are reassuring. So we had just talked about at the beginning that dyspnea and chest discomfort can have a lot of really morbid causes that you want to keep an eye out for. So the fact that you said that his exam is overall reassuring, the vitals, there's nothing that's so alarming, and even some of the basic labs are fine, makes me less concerned for kind of a life-threatening cause here. Some of the things that, the kind of big piece of data that we have is the tachypnea exacerbating during palpation of the neck, chest, and back pain. So to me, that's like, I'm thinking of, well, I was about to say costochondritis, maybe. I'm not sure why that would cause pain in the neck. But costochondritis came to mind. I think some people in the chat mentioned, anxiety. I think that's definitely something to think about here, which can cause someone to feel like they're short of breath and have some chest discomfort. And so I think at this point, I would want to be talking to the patient actually a little bit about kind of this, maybe the social history. I mean, this has been going on for 3 months. So I'd maybe ask, what happened 3 months ago, to kind of what do they think may be contributing to this. So I think ask the patient a little bit more for some information, making sure they're not taking any medications. I know you said no medications, but kind of really kind of going back to that, ask if they take other drugs or medications, and try to get a little bit more history about if anything happened 3 months ago that's out of the ordinary. And then I guess in terms of further information, you're going to share a chest X-ray with us. I think an EKG will be important here. So that's what I'm thinking right now.
Gosh, I'm so glad you're thinking something, because I'm completely stumped. I have no idea what this is.
Yeah.
God, I don't think I would even palpate this person's neck, back, and
Yeah.
move to like figure out, because okay, if I were seeing this patient, I would be like, everything's normal, and I probably wouldn't have felt that palpated that area. And so I think I love what you did. You're like, I don't know what to make of this abnormality. I don't know what it means. So let me go back to the fundamentals. And the fundamentals are like, what is bothering this patient? Let me zoom in on that and try to get clarity on that. I think that's such a smart move. All too often, I think the real-time instinct is to dismiss this finding and to be like, it's just weird. I can't quite explain it. So it's annoying me. So I'm going to forget about it cognitively. And I think your instinct wasn't that. And it was to like explore and dive deeper, which is just so incredibly mature and diagnostic saving. Yeah, and I think in general, when the lungs are clear, that doesn't dismiss the possibility of pulmonary disease. I think the stethoscope is only limited in its sensitivity. So I would be like, I'm not sure what to do with this. My other key move in patients where I'm stuck is, of course, as you emphasize, to go back to the history, but also to do an ambulatory oxygen saturation. When patients have dyspnea on exertion for 3 months, sometimes you have to bring that out with exerting them. And so I might do a little, go on a little walk and gather the history that you're alluding to on said walk while monitoring the O2 sat. So keep that in your back pocket too, as another strategy when you're kind of like, I'm not sure what's going on. All right, Yasmin, I don't know where this is going to go, but I'm really excited.
Yeah, this is an interesting case. So the X-ray showed, yes, by the way, I forgot to say LDH, ILP normal. The X-rays showed an heterogeneous lesion in the right posterior mediastinum with demarcated margins of approximately 5 by 4 and mediastinal widening. Do you want the CT scan too? Yeah.
I would hold off on
Yeah.
the CT.
Oh no.
Okay.
It might tell you, no, I say that because the CC is so gosh darn good, it might tell you the answer.
Okay.
So you'll lose your chance of being able to think through it. Yeah.
Okay, let me just make sure I heard this right. Heterogeneous lesion in the right side of the mediastinum with mediastinal widening. Is that right, Yasmin? Just want to make sure I heard that right.
And Marlena, just to help you, I think she also mentioned that it was posterior. Is that right, Yasmin? In the posterior mediastinum.
It was posterior.
And even you can just start as mediastinal, and then we can discuss together what the value of it being posterior is, if anything.
Yeah.
But yeah.
Okay. This is interesting. I was not expecting to get this data point. So I know for mediastinal masses, what's important is to think about the location. So is it anterior, posterior? And I'm kind of forgetting exactly. I know there's some, there's like mnemonics, like I think for, I hope I'm not getting this wrong. Like I think for anterior, but please correct me, you can have like a thymoma and then a lymphoma. I'm actually forgetting the location of kind of where those are, but heterogeneous lesion in the right side posterior mediastinum. I'm a little bit stumped here. I'm not entirely sure. But I know that a thymoma can present as a mediastinal mass, and I'm forgetting the exact location. I think that's in the anterior portion. The posterior mediastinum, could it be a lymphoma? But he hasn't really had signs of inflammation like weight loss or fever. But I mean, I think that's something to consider, especially in like a 29-year-old. Yeah, I'm a little bit stumped now, but some of the things that are coming to mind are a lymphoma, but some of the history doesn't exactly line up with that, but that's would be like a do not miss cause here. And that's where I'm at, but I would love some help. I see from the chat, people mentioned a teratoma, kind of a thyroid. I know the thyroid would be more anterior. Maybe the mediastinal widening is just from the lesion. But I mean, to be honest, I'm a little bit stumped. I'm not entirely sure what to make of this.
I don't think you can, because the X-ray is just not good enough, and I think that's why Yasmin was itching to help you with the CT scan. I think you're being stumped is just inherent to the data that you have. I don't think you can actually come to a conclusion. I'll just share like a overly simplistic way of thinking about mediastinal widening, which is to ask the question, is it an existing structure in the mediastinum that has enlarged? So there's something that you already know. So is there a big aorta, or is there a big pulmonary artery? Or has the thymus gotten tumorous, causing a thymoma? Or has the thyroid, as you said, descended into the anterior mediastinum, or the parathyroid even? Or is it something that shouldn't be there, that developed there? And the thing that shouldn't be there that developed there is usually lymph nodes, which are located throughout the mediastinum, causing a lymphoma, anterior, middle, posterior, anywhere. And then the other thing that shouldn't be there that can grow there is a teratoma. So quite simply, you're like, is there something that is always there that develops an abnormality, or is it something that shouldn't be there? And the two shouldn't be there are lymphoma and teratoma.
I like that approach.
Yeah, so to guide you a little bit in terms of the posterior mediastinum, ask yourself, and you know, us internists, both you and I are tend to be very far from anatomy.
Yeah.
So let's tag this together. So if you just close your eyes and picture the posterior mediastinum, what native structures do you imagine are all the way back there?
So posterior mediastinum.
Like you're in the heart and you go right behind the heart. What do you think is right behind the heart?
So you have, vessels, like your kind of aorta goes back there.
Exactly. Boom.
Yeah.
Aorta courses back there. The pulmonary artery doesn't quite make it back to the posterior, but the aorta is right there. And anything else on the left side that is next to the aorta that you can think of?
Like the esophagus?
Yeah, boom, there you go. Nailed one of the biggest ones. So when you see a posterior mediastinal mass in an older adult, you really have to worry about an esophageal tumor. So aorta, esophagus, and what about behind the esophagus, all the way like dead back, all the way at the end?
Like the spinal cord?
Exactly right. So now this is the connection. So ask yourself, what might you press on that causes radiating symptoms that links into the spinal cord? This is the leap, right? Like this is the leap of analogical reasoning that either you make it or you don't. But you like there, I'm thinking about the esophagus, but he's too young. I'm thinking about the aorta, but why would a 29-year-old has all of a sudden have aortic issues? And then your only clue is that when you press on him, he gets like radiating pain.
Oh,
Yeah.
like, so I know if if you press here, would that cause kind of vagus nerve?
Yeah, I
No,
think you said the right word. Exactly right. You said the key word. Is this a nerve issue? So is this a neurogenic tumor, a neurofibroma, or a schwannoma? So I think, at the end of the day, we have a mediastinal mass and we need a CT scan to clarify this. But what's in the posterior mediastinum? The two main structures in the posterior mediastinum are the esophagus and the vertebral column. And the esophageal cancer is a possibility, but then nerve sheath tumors are one of the most common. You can also get two things that shouldn't be there that go there. And the first example is you already said lymphoma, and then in a young man, a sarcoma. So all that soft tissue back there can undergo sarcomatous degeneration. It's also actually not an uncommon site for extramedullary hematopoiesis, which is when bone tumors when hematopoietic elements just form there. So I would say like the DDX will be clarified by CT, but the question is it esophageal? Is it aortic? Is it neurogenic? Or is it stuff that shouldn't be there? Lymphoma, sarcoma, or extramedullary hematopoiesis. And again, the differential is just built by iterative practice. And I've only seen maybe 5 or 6 cases of posterior mediastinal masses. So this one will count as a big rep for me too. Any thoughts or questions about that, Marlena, before we pass the mic to Yasmin?
No, that was really helpful. I think, as I said, just in medical school, when I think of mediastinal masses, I know the location is so important to think about the differential, and I'd kind of just forgotten the things to think about in the posterior. But it's helpful to think through, the anatomy, what structures are there, and I liked your approach about what structures are always there versus kind of something new. So that was really helpful.
Awesome. All right, Yasmin, enlighten us, please.
So the CT scan revealed a 5 centimeter, it has contrast, 5 centimeter pulmonary nodule in the lateral segment of the right middle lobe. Yes, with peripheral nodular enhancement, gradual filling, and that's it.
To show you
gradual central filling. Sorry, gradual central filling.
Okay, I'm just thinking here for a sec. Let's see. 5 centimeter pulmonary nodule in the right middle lobe with peripheral. Interesting. I I don't exactly know here, but let's try to think through this. So it's just one nodule, is that right?
It had peripheral nodular enhancement, and gradual central filling. Yeah. Sorry, I had like writing it all fast as they were telling me this case.
Yeah. So I think this is, I take what here is that I have a lot to learn because I don't have such a structured approach to pulmonary nodules, but things I would want to make sure not to miss is this some kind of malignancy? So does this nodule represent a malignancy? Does the nodule represent an infection? We haven't seen, at least from kind of the history and from the vitals, we don't see so many signs of fever or weight loss or things like that. And so I'm trying to connect this 5 centimeter pulmonary nodule with the posterior mediastinum widening. Those seem like things. I'm not sure if they're referring to the same thing. But in terms of next steps, would you want to, I mean, biopsy is very aggressive here, but I just want to get more information about what that nodule is. And the way I think about how to do that is biopsying it, but that is extremely aggressive. So maybe there's some next step before that that I just don't know of. But I'm not entirely sure here. Ravi, what do you think?
Gosh, there's like I don't have anything to add to your differential about pulmonary nodules. I think whenever you have a solitary nodule, the key question is it malignant or not. I'm just amazed by the imaging here. We had such a concerning read on the X-ray within the mediastinum, and I think it just goes to show you that when you're using a blunt instrument like an X-ray, you can be so easily misled. And I think that's why you really have to follow up your X-rays, the CT scans. And I'm shocked to see that there's nothing in the mediastinum, that this is all in the lung. Yeah. And yeah, I mean, the approach to pulmonary nodule was to first figure out if they're multiple or single, and if a single one, to accumulate some features to say, do you need to biopsy it or not? And I think the size here is concerning. It's 5 centimeters. So, and I don't know what the enhancement pattern, I just don't know this stuff. Like I don't have a refined understanding of which to biopsy or not, but I think that's the key question. So all I said is absolutely nothing. And I think I learned that I have to refine my approach to pulmonary nodules, but I think a more precious lesson is just how blunt an X-ray is sometimes and how valuable a CT scan is.
Yeah.
Agreed. All right, Yasmin, mic is yours.
So this patient was taken into surgery, but since this was a patient in internal medicine, we don't really know what happened, but the diagnosis was mediastinal cavernous hemangioma, which I was looking at that, and there's actually a lot of like very similar cases to this one. These hemangiomas are very rare, like very rare. They are, according to literature, less than 1% of mediastinal masses. And you have to think about hypervascular mass when there is a strong enhancement after contrast media administration. That's why they didn't do a biopsy, because they thought this will bleed. So we will definitely, they took him to surgery. They decided to take it out. And each compartment of mediastinal mass, and I will send you the link of this article about it. It has different diagnoses, several entities such as Castleman disease, paraganglioma, vascular malformation, ectopic parathyroid adenoma, hypervascular metastasis should be taken into consideration when we find a hypervascular nodule or mass. These are like, for me, those are very like obscure diagnoses. I would have never got to the diagnosis if somebody told me this, especially with a patient so young. I found there are like very little case reports in the literature available, and there is actually one that looks like very much like this one. So yeah, it's almost, it doesn't have a predominance in male or female, doesn't have a predominance in age. It just happens.
Wow. I'm blown away. Yasmin, that was such an interesting case. Wow. And I think my reflections on this is that one, it was so much fun to discuss and such like a helpful exercise, because we started with dyspnea and chest pain that are such common chief concerns, and really got to talk through a structured approach to that and the do not miss diagnoses, which for me was extremely helpful. But I definitely kind of have some gaps in my knowledge in terms of how to approach pulmonary nodules, how to approach mediastinal masses, and thinking through the anatomy. So it was really such kind of a privilege for me to get to discuss some things that I have a little bit more confidence about, like an approach to dyspnea, versus things that I really feel less confident about, like mediastinal masses and pulmonary nodules. So you presented it so beautifully, so really thank you for that, and a lot to learn. Thank you.
I have 3 quick things to reflect with you about, but 3 and quick don't usually go well together. The first is, I think, Yasmin, you jumping in and presenting such an intriguing case that has so much is ripe for learning in so many simple ways. How does dyspnea and chest pain interact? How do we work up a patient with shortness of breath? What is the value of the X-ray and the CT? What's the DDX for mediastinal mass? Is it just because the X-ray says it's mediastinal, does it actually mean it is in the mediastinum? So many cool things, and it wasn't even your case to present with such clarity is absolutely amazing. So thank you. And the other thing I wanted to reflect with you all is for all of you as learners or educators, I think you all may have noticed that as many of you are here at VMR a lot, there's a little bit of a difference in my facilitation style today. And that facilitation style is actually trying to find the edge of Madalena's comfort zone in public. And
Yes. Oh.
Oh no, Robbie, I think you kind of broke up. At least for me, you did. I'm not sure for everyone else.
oh no, you lost me. Uh-oh.
Okay, you're back. You're back. You're back.
Okay, I just want you to know that I think that's an interesting concept of like, how far do you, like, what is psychological safety, and how do you interact? How do you find, how does that play in with the other phenomenon? And the other phenomenon on VMR is the concept of high achiever inertia. And so whenever all of you are probably vulnerable to this high achiever inertia phenomenon, when people see that you're doing so well, they keep saying, okay, cool, like you're doing a really, really good job. And they actually let you glide along in that inertia. And so I hope all of you strive to find that healthy balance of wanting to let somebody grow in a very psychologically safe environment, and the notion that people who are actually doing very, very well get less growth opportunities because there's not, it's harder to actually find the space to grow. And for me, what I witnessed, I have no idea how you felt, Madalena. I witnessed somebody like absorb the challenge and rise up to it. Like I almost could see you be like, whoa, okay, like I don't think I expected that question, and then rise up to it. And I think that is an incredible mindset. It is the definition of growth mindset. I think putting that on display for all of us to see today, it was really, really cool. I really appreciate you pushing yourself in front of all of us and showing us that vulnerability, and continuing with your incredible equanimity. It was a real treat to see, and it certainly pushes me. I can't claim that I'm good at this, but I'm definitely going to keep trying, because all of our brilliant CP Solvers team members just constantly challenge me in helping them grow more and more and more. So thank you guys for a great case. Thank you, Yasmin. And thank you, Madalena, for being such a great sport, and for continuing to dance even when it got really, really hot there.
Thank you for doing this with me. It was so fun.
Take care, y'all.